Hello, good evening everyone, and welcome to the EUROGEN webinar programme. Just before we get going, I'd just like to take a couple of minutes to explain a little bit about what a European reference network is and does. So EUROGEN is one of 24 European reference networks created by the European Commission in 2017. So they cover all different medical fields. And EUROGEN concentrates on highly specialised surgery for patients with uro-recto-genital diseases and complex conditions that all need highly specialised surgery. So our aim is to deliver quicker specialist evaluation and more equitable access to high quality healthcare for all our patients who need the highly specialised surgery. So some of our activities, and this is the same for all the ERNs, is we do virtual consultations across border where the experts based in one of our 57 member hospitals they can have a secure online consultation, video consultation, looking at all the medical data of the patient and recommend the best treatment or different surgical approaches. This is a secure tool provided by the European Commission for all the ERNs. We also do training and education activities such as this webinar programme, and we also have a clinical exchange programme so that we can move healthcare professionals between our various hospitals. We also work together on clinical guidelines, and right now we're working on adapting and adopting one on anorectal malformations. And we are also developing a EUROGEN registry with the aim to track our patients long term over a 25-year plus period. So hopefully a lot of learning and research should come out of the registry as we move forward. So without further ado, this evening's webinar is about the advantages of centralisation and care. And the presenters are Dalia Aminoff and Eberhard Schmiedeke. And this evening's webinar is joint with another ERN, Ernica, and is supported by the ARMnet, which is a consortium. And Dalia Aminoff is head of the patient organisation AIMAR, which is the Italian organisation for patients with anorectal malformations based in Rome, Italy. And Dr. Eberhard Schmiedeke is the paediatric surgeon from the Clinic for Paediatric Surgery and Paediatric Urology in Bremen in Germany. And he's also a member of the Multidisciplinary Expert Advisory Board of SOMA, which is the German patient organisation for anorectal malformations and Hirschsprung's disease. And it's personally an absolute joy to welcome both Dalia and Eberhard. They've been with us right since the very beginning, back in 2016, when the ERN was really just an idea on paper. So it's an absolute pleasure to have you both here this evening, and thank you both for sharing your expertise with us. Dalia, I'll give you the floor.
Thank you very much, Michelle. Thank you for the introduction. Let me go through through the slides. Here, Eberhard. Okay. Eberhard, maybe
thank you very much, Michelle, for the friendly invitation, introduction. Good afternoon also from my side. You see our agenda. First, Darren will give us an overview about your thoughts to the subject with 5 short questions. Afterwards, Dalia and I will present the patient's perspective and the surgeon's perspective. By the way, all we consider in the next hour touches not only anorectal malformations, which are part of ERN EUROGEN, but also morbus Hirschsprung, which is part of ERN Ernica, and the other congenital malformations in whatever ERN they are located. Finally, we plan to have at least 15 minutes to discuss your comments and questions. If the references on my slides are too small to be deciphered, please send me an email afterwards. I will repeat my email on several slides on my last slide too. Thank you very much.
Okay, thank you both. So we'll go with the polls now. So we've got the 5 questions there. So we're going to go for question 1. to start with. Hopefully this is, I've got them in the right order here. That's good. So everyone should see the poll come up in a second. You've got options of yes, no, or I don't know. I'll give you around 30 seconds, 40 seconds to answer. So I'm going to launch the poll now. So it's in progress. So please make your selections. So give it a few more seconds. We've got about, I think, 86% of you have voted, so that's very good. A few more people, maybe. Okay, I think it seems to have stopped, so I'll leave that there. I don't know if you can see the results, Eberhard and Dalia, but
wow.
yes, and yes, saying answering yes, and 4% saying no. I don't know if you want to comment on any of this afterwards, or just let me carry on with the polls, Eberhard, or
Carry on, yeah, you just
Carry on, yes.
no problem. So that's that one done. We will then go on to question 2. Have you ever feared that the centralisation might mean that you treat less interesting cases and do less interesting procedures? So I'm going to launch that one now. So please start voting. Okay, we're up to nearly 70%. Give another 10 seconds, I think, just to finish this one. Okay, 4, 3, 2, 1, and I'm going to close that. And the results are there. A little varied. Okay.
Very interesting.
We'll move on to the next one.
Mm-hmm.
Okay, question 3. If you or a member of your family would need major surgery, and you can choose between a clinic performing it once or twice a year and another more distant one doing it 10 to 20 times, which would you choose? So the poll is now running. Okay, so 75% voted so far. About another 10 seconds. 5, 4, 3, 2, 1. I'm going to close that. So 86% people voted in that one. Here are the results. I don't know what you were expecting, I don't know, but so question 4. Do you treat adult ARM patients? Okay, and that's open now. Okay, already up to 75%, 82%. Okay, a few more seconds. If anyone else wants to vote, please do so now. 5, 4, 3, 2, 1. And closing. So the results are there. Okay. And we shall then move on to our final question, which is, if not, do you know colleagues in adult medicine you can and do send them to? This is mainly for those who answered no to the previous question. It's open now. Okay. A few more seconds. Close it. So 5, 4, 3, 2, 1, and close. And here are your results. Okay.
Yeah, thank you very much. I think we can discuss it together with the other points in the discussion in the end, because we will touch all those subjects during our presentations.
Yeah. Okay, so I continue. So I would like to talk today about the advantages of centralization of care seen by our perspective, by the patient's organization's perspective. First of all, I have no conflict of interest. Just to give you a background of some numbers, in Italy last year, almost 400,000 children were born on a population of 60 million people. The incidence of anorectal malformation is about 110 children per year, but we know that half of the cases are less complex, half of the cases are complex. And if we consider the 52 pediatric surgical units doing anorectal malformation, let's say, or Hirschsprung disease all over Italy, I must say that if we divide this number by the population born and the incidence, we will see that the average is almost 2 patients per year of children seen and operated. If we go to Germany, the situation is almost the same. Last year, on a 800,000 almost children born on a population of 84 million people, the incidence of anorectal malformation was 220 children per year. 50%, as we said, are less complex cases, 50% are more complex. And if we divide this incidence, these 220 children, to the 103 pediatric surgical units which are correcting anorectal malformation and Hirschsprung disease in Germany, each center will operate only 2 patients on an average. I would like to show you a couple of cases that there were preventable catastrophes if centralization was in place. The first case is about a boy who is 13 years old today, but he was born in a small city where there was a pediatric surgical unit. He had all the procedures done in the 3 steps, and he developed, after the closure of the colostomy, a long rectal stenosis. And the parents were taught to do dilatations, but the dilatations were very painful and almost impossible to be done. So the mother called our organization, and we referred them to a specialized center where there are committed surgeons on anorectal malformation, and they had to reopen the colostomy, redo the PSAR, and remove 15 centimeters of the rectum. Of course, the child became incontinent and now is on a regular bowel management. The second case is a case of female, 46 years old, born with a vestibular fistula, and she had a correction before the Peña procedure, but she had a normal life till she reached menopause. When she was in menopause, she has a complete prolapse of the rectum, but the whole cylinder. And unfortunately, she came across a television report where she saw a colorectal surgeon. She addressed to this colorectal surgeon, and the surgeon, by correcting the prolapse in the way he knew, he just moved the angle, changed the angle of the rectum, and therefore she couldn't empty herself anymore. Now, she arrived to us as well, and we referred her to a center of expertise where they put her on a bowel management and a physiotherapy for the pelvic floor, but she can hardly walk even today. So I took these slides by the courtesy of Dr. Alberto Peña because it showed us that what was surgery before 1970s, and I found it quite interesting that surgeon could do a lot of procedures, and as Dr. Peña said, but with very bad results. Nowadays, when a child is born with a congenital malformations, the parents already learned where to go on internet to look for the best place, trying to understand where is the best surgeon, which institution has experience in the management of that particular malformation. In addition, parents are more and more educated and knowledgeable, and they're asking, for example, questions to doctors like, how many cases have you done, or who is the best one? So little by little, even there is a movement from the patient side to find the best places and where they have done a lot of cases. So why it is important for the patient organizations to have centralized care? Because we think that this is the only way to take care of the patients from zero to the entire life of the patients, by having a transitional care with the adult multidisciplinary team. And we think that due to the high volume of the patients seen by the center, it is possible to carry out research on different aspects that are not considered today, like psychology, sexuology, social problems. And we think that it is important to train new surgeons on colorectal problems, share the knowledge with centers that they have high volume cases, learn more about the specificity of each patient. Thank you. I leave the floor to Eberhard.
Thank you very much, Dalia. Darren, where am I to share my screen? Okay, thank you very much. Okay, you can see my screen?
Yes, we can.
Perfect.
Yes, yeah, perfect.
Okay, thank you very much, Dalia. I will now describe both the evidence requiring centralization and its actual status. Then I will refer to some of the most frequently heard counter-arguments and conclude with a profit and loss account. Just for your better understanding of my background, my special area of expertise is the follow-up treatment of ARM patients. At a certain point in my career, I decided that correcting these malformations in a decent manner requires more special surgical gifting and training than I could offer. So I left these reconstructions to my more gifted and better trained colleagues in our clinic and beyond. I focused on ARM follow-up, a subspecialization which greatly increased my job satisfaction. We will look at this subject later. While doing so, also at SOMA meetings, the German patient organization, my team and I see patients from all over Germany and from relatively high volume to very low volume clinics. And we see a wide range of surgical results, including devastating preventable complications and mistakes. This conflict of interest slide is usually skipped in a millisecond. But if I am honest, I have to concede that what I present to you in the following might mean that my clinic, after the realization of the long overdue centralization, will no longer treat anorectal malformation patients the way it does now, and this might affect my job satisfaction. This puts me in a conflict of interest. Do I try to defend the existing system which serves me well, or will I promote the patient's interest by fighting for fewer centers with more cases, more experience, and better results? Although this might ostensibly reduce my job satisfaction and reputation, and also of my colleagues. This is an unpleasant subject. That's why I did not start to think about it by myself. But when I applied with my clinic to the European Reference Network of Rare Diseases, the EU forced me to do so. The EU also requests scientifically based minimal numbers of patients treated and procedures performed for each condition. So we started to look into scientific evidence. To ask for minimal numbers means to examine the volume-quality relationship, which is common sense in any training and undisputed in general life and in the education of surgeons. This groundbreaking paper showed already in 1979 that postoperative mortality decreases with increasing case numbers. Since then, mortality rates improved, yet the difference between high and low volume clinics even increased. Mortality is a good proxy for other treatment outcomes because it is easy to access, extensively documented, and quite independent from researchers' bias. More important outcome parameters in ARM, like fecal and urinary continence, sexual functions, and psychosocial well-being, are far more difficult to assess and become evident often only many years after the primary reconstruction. This is the famous learning curve. The more complex a procedure, the higher the case number per clinic and year, which is necessary to reach the plateau of the learning curve. In plain gallbladder removal, 1 case per clinic and year was enough. In colectomy or hip replacement, as shown in the diagram, 50 to 100 cases were necessary, and in open heart surgery, the plateau was not yet reached by the clinic with the most, respectively 200 cases. Numerous studies since then have confirmed and detailed these findings. They are more scarce for congenital malformations because of their rarity and inhomogeneity. But we can compare the complexity of ARM reconstruction to other investigated procedures and have to conclude that the plateau of the learning curve will be reached most likely not before at least 50 to 100 reconstructions per clinic and year. These numbers are, as you can see, the range which is already required in adult surgery by payers, governmental law, or surgical societies, and they are already realized in pediatric cardiac surgery. The German government recommended minimal numbers for esophageal surgery and other complex, rare, and plannable procedures in adults many years ago, but the surgeons did not care. The average case number remained by 6 cases per clinic and year. Because of the clear volume-quality relationship regarding mortality and also treatment costs, the health insurances stopped paying the clinics not meeting the minimal number of 10 in 2018. From next year on, the minimal number will be raised to 26. An average case number of 60 cases per clinic and year is anticipated, with a minimal increase in travel time. Concerning the situation in general pediatric surgery, centralization of biliary atresia in Great Britain is a good example for the problems we struggle with. In the 90s, there were 15 clinics doing this surgery in the UK. Mortality was clearly higher in the low volume clinics, but the pediatric surgical community reacted with, I quote, considerable furor when the forming of only 2 centers was proposed, which is a clear example of overruling secondary interests. A mother whose child had died in a low volume clinic after surgery founded a patient organization, and after futile talks with the pediatric surgeons, decided to inform the Rainbow Press. The surgeons were accused in public as dabblers, amateurs, quacks, charlatans, and only after that centralization was imposed. The low volume centers stopped doing these operations and the results significantly improved. In the aftermath, bladder exstrophy was centralized too in Great Britain. But in esophageal atresia, a procedure essential for the identity and self-image of a pediatric surgeon, even looking at the numbers of the volume outcome relation was avoided and refused because everybody knew the results in advance. Centralization would have become as inevitable as it is in biliary atresia. What is the present situation? In Europe, even the specially dedicated clinics of the ARMnet cover a wide range of very low to medium numbers of cases per year. Higher numbers, which might reach towards the plateau of the learning curve, currently occur only in densely populated Asian regions. Some European countries already realized a certain degree of centralization for all of their patients. Their numbers do not yet reach the plateau of the learning curve, but they are of course far better than the situation, for example, in Germany, where there are university clinics which perform any ARM reconstruction only once every 3rd year, and other clinics in Germany once every 10 years. Bremen, by the way, is in the upper third. The occasional surgery in such very low volume clinics produces preventable catastrophes on a regular basis, like damage or complete resection of the anal canal in transanal Hirschsprung surgery, resulting in lifelong fecal incontinence of the affected child. We see this mistake happen on a regular basis, constantly. By the way, the situation in London is very much like in other big cities in Europe, several competing clinics taking the cases and the experience from one another. According to self-published results, there is a well-known referral center in London treating 2 newborn cloaca patients every year, and another clinic a few kilometers distant embarking on such a demanding procedure only every 7th year. In general, as a consequence, the required minimal numbers in the voluntary ARMNet and in the official eUROGEN are low, in my eyes, still painfully low, because they are located in the very beginning of the steep learning curve. At the same time, their obligatory realization all over a country like in Netherlands or Sweden would mean a huge progress compared to the occasional surgery still performed in most countries. What would centralization mean for the number of clinics per country? A neonatologist provided me with a nice picture, so please allow me to shortly sidestep to esophageal atresia. Out of 74 clinics in Germany reconstructing it, only 21 did a minimum of 3 cases per year. This is a geographic distribution of those 21 clinics. The distance to reach them from all of Germany are acceptable in my eyes, given the fact what is at stake for the children. By the way, there are 5 cities with more than 1 clinic represented, a further opportunity for centralization without any prolonging of travel distances. In anorectal malformations, only 23 out of 103 clinics reach a minimal number of 4 cases per clinic and year. Their geographical distribution will most likely correspond to the one seen in esophageal atresia. Centralization is called for since decades, also from many pediatric surgeons. Why is it so difficult to realize? There are many arguments which are used to fight it. The correction of congenital malformations is a core feature of our professional identity as pediatric surgeons, and many colleagues fear to lose interest in cases and reputation. Thank you very much for your honesty that a third of you confessed this, in spite you think that centralization is necessary. Yet, to treat these patients continuously in a fragmented manner is a failure in a conflict of interest. But if you stop the attempt to master the complete field of pediatric surgery, despite very low case numbers, and concentrate instead on a subspecialty you like and know, you will most likely increase your job satisfaction. Parents of a newborn with a serious malformation asking for referral to a more experienced center are frequently told by the treating surgeon that this would be too dangerous for their child. At the same time, critically ill newborns with severe diaphragmatic hernia or cardiac malformations are transported without problems. Parents and patients will eagerly travel long distances to reach higher quality of care if they know about the advantages. And those who are not able to do so should receive the necessary help so that they too can provide their child with the best treatment possible. Future training, of course, is a very significant concern. This training has to change so that decent follow-up in clinics closer than the center will be possible. Rotations will become mandatory, and yet not every pediatric surgeon, after finishing his or her career, will be his or her training, will be allowed to do any procedure anywhere in the future. The case number per clinic does not say everything. The expertise of the single surgeon is crucial in ARM reconstructions, yet it is even more difficult to assess and to steer. Structural quality has to be taken into account, of course, yet you need sufficient patient numbers to establish a decent structural quality. There are things the average pediatric surgeon loses in a process of centralization. From an emotional point of view, they might be regarded as positive or negative. But if we become more honest and transparent and cooperative, all of us can win something very precious, the more justified trust of our patients. And all of us gain expertise and job satisfaction by concentrating on the respective fields and no longer trying to be a jack of all trades. And those working in the respective centers for congenital malformations, of course, will gain expertise and skill in these fields. So we can sum up that the volume-quality relationship is well established also in pediatric surgery, yet there is also ample evidence for the resistance of many pediatric surgeons to acknowledge these facts and to draw the necessary consequences. This is the main reason why we still have a high level of fragmentation of care, bringing about preventable catastrophes for the patients on a regular basis. Although the plateau of the learning curve is hard to reach in these rare malformations, it sets the aim towards we should move. The forming of regional networks of pediatric surgical clinics which share cases and experience is a possible next step. Yet, looking at the experiences of the last decades, mandatory minimal numbers seem to be inevitable. Thank you very much for your attention.
Thank you, Eberhard, and thank you, Dalia. So yes, I'll now invite people to ask questions. So a reminder, if you want to type your question in, please do so, but you can also raise your hand. If you click on the raise hand button, then I will kind of unmute you and allow you to speak. So the choice is yours. Just while we're waiting, just a reminder to everybody who's attended, if you had any technical problems or anything, this is being recorded and will be put onto our GoToWebinar platform and on our YouTube channel tomorrow, so you'll be able to watch any of it back. Also, you get a survey straight after the this event. If you could fill that in at some point, that would be great as well. We've just been going through the surveys from previous webinars, and also we did an annual survey as well, and we're looking to implement some of the things that came out of that. One of them is precisely the more interactivity in the sessions. So please do fill it in. We do take into account your views. Okay, so no questions so far. Oh, here we go. Farid has asked. So 1 second, Farid. I shall mute you. I'm not sure I can unmute you, Farid. It seems to be. Are you there, Farid? Can you speak? Your microphone's not showing up as green. That's all. It's like it's grayed out. So I think that might be a problem with yours. Oh, here we go. You're on green now, so you should be able to speak. Hello. There might be a problem with your audio, Farid, unfortunately. Maybe if you try dialing out and back in, perhaps.
Or you use the chat function to write down your questions, which is possible too.
Indeed. Is that a question here? Yeah, quick look. So we've got a question that's been typed in from Taurai. It says, thank you very much for these thought-provoking presentations. I'm pro-centralization. However, is there not a risk of creating elitists in paediatric surgery? Obviously, that would be unhealthy in the profession.
Any risk to create, sorry?
Elitists, a special elite, you know.
Okay.
Pediatric surgeon, first class and second class. Who should answer? Dalia, you want?
I don't think so, actually. I think that it is important to have a center where surgeons will learn from each other and will share their knowledge from each other to each other, because we see so many preventable catastrophes. We see a lot of children that they are operated no matter what for anorectal malformation or Hirschsprung disease with not a good result. This is the point. And then we ask ourselves why the surgeon is not able to send it a few kilometers away there. I mean, there is another good center. So I think it's better to work on, I mean, anyway, medicine is going through centralization anyway, and so I think it's better to have it, to share the knowledge rather than to. What do you think, Eberhard?
I think that we already have an elite, you know, whether you're a simple pediatric surgeon in a clinic or whether you're a professor at a university clinic, it's a difference in social hierarchy. And so we have to deal with this status things. It will never disappear. I think we should be free from attributing our worth as a person from the degree of surgical procedures we do. And as long as we have an elite of professors of pediatric surgery who do a reconstruction of an ARM every third year, who really don't know the basics, I've met them, I've heard them, who do things and teach things which leave children incontinent for life. Professors of pediatric surgery, I've met them, I've heard them. This is an elite we are not worthy of, you know, and which our patients do not deserve. The parents bring their child into a university clinic because they think this is the professor, this is the elite, my child will be treated properly, and the opposite is the case. So we have a situation we have to change. We have to get an elite which is worthy of being called so.
I do agree.
Okay, we've got another person who wants to ask a question over audio, so I'm going to try this one. Hopefully this one will work. So Anton van Dijk, I'm going to unmute you now, so hopefully you'll be able to speak. Hello.
Oh yeah, Paul. Hi, Paul Bruns. I use the one of Anton van Dijk too. Paul Bruns from Groningen. We work, of course, already in country where we have centralization. And I would like to comment on what you said, to get privileged pediatric surgeons. It doesn't mean to be like that, because we had this struggle in the Netherlands because we went to centralization, and we then also found out it's not a good idea to go to one place in the Netherlands or two places and do there all the funny things, because it means in the rest of the Netherlands that the general quality of the healthcare will go down for children. So what we decided that there are of these pediatric surgical centers, some of them will take care of lower like anorectal malformations, other ones will do esophageal atresia operations. So we divided it between the different centers, so that indeed the specialization on every field is only available in a few centers, and with that you keep the good quality. But of course, I'm honest, we are already in a country where we do have very far centralization of the pediatric surgery. Yeah.
Thank you very much, Paul.
Thank you, Paul.
Okay. So we've got a few other questions, so some comments as well. So 1 second, just quickly to go to Mark Miseres, who's asked a question. Hello, Mark. So question to Eberhard and Dalia. How to decide who does what? Should we use data of high quality registries to decide? So is that the first step?
Yeah, registries in Germany don't work because the surgeons won't answer, and it takes time for a good registry. Yeah. I think you have to start with the numbers which are already there. And in the ERNs now we start a registry both of the number of procedures performed and which kind of arm. So is it only a perineal or is a high urethral or falsely so-called cloacal form? So yes, I think we have to take the data which we can get, try to make good registries, but this is expensive. And this is the point to start with. Adult surgery shows us that it's possible if you want to. Biliary atresia shows us that it's possible if you want to.
Okay, thank you. So a question from Polona. What is the solution if the country is small and there are 4 to 7 cases of ARM yearly? How can one connect with other countries in the EU? Which are the centres that would cooperate?
Dalia.
Well, yes, we have the answer for that because we brainstormed about that a lot. So we thought that in cases like small countries, there should be a hub and where the patient can go for first emergency, a colostomy, for example, in the case. And then the patient should be referred to another country, but then you have to work with the health system, and the health system should pay for this, for the patient to go abroad to a better center. Because otherwise, I mean, we will not solve this problem. There are small countries that they are not, I mean, for natality reasons, because they don't have enough population, they will not see enough patients to become experts. So this is the only way to solve it.
And that's what the ERNs are all about. It's a European project. Absolutely. Just because of this reason.
Absolutely.
Indeed. Okay, thank you. So a few other things here. So this next one's from Kate Tyler. She says, thank you. I believe centralisation should be there for newborns to adults. We deserve the very best from specialists who are highly skilled. It is what they would want for themselves, their children and their loved ones. And we need to trust. So thank you, Kate, for those comments. Farid, who, yes, apologies, Farid, we couldn't get you on the audio earlier. I think, oh, so you, it was a couple from Farid here. So he said, in our country, we delay complex anomalies due to the lack of expert surgeons. And do you advise for your centres to go abroad and operate future colorectal operate with future colorectal surgeons in a country with a high volume of cases?
Yeah, that's already done on a voluntary basis. It's not institutional. My field is Germany, is Europe. Africa is not my cup of tea, but I know of some very interesting initiatives to do so.
Yes, and even from the States, Mark Levitt is doing that on a voluntary basis. He has a group of people who go, surgeons who go abroad to operate in different countries. So you get, and then it's important to form the new surgeons by sending them abroad. For example, if you send them not only to Asia, but if you send them to South Africa, for example, they have the possibility to learn a lot. Giulia Brisighella is a good example of this. She went from Milano to Johannesburg, and she is operating on hundreds of children with anorectal malformation and Hirschsprung disease.
There is a very beautiful initiative, this Cure for You, isn't it called this way?
Yes.
A man from Belgium who has good connections to Pakistan and who is building up a very strong cooperation for ARM children.
Yeah.
Yes, indeed, absolutely. Okay, I hope that, yes, Farad, so I guess the answer to your question is yes, definitely advise people to go abroad. So just quickly looking through, so we've got a question from, or a comment from Joe Curry in London. I'm a colorectal surgeon in London and listen with great interest to your talks. The lack of widespread specialisation in the UK is, in my view, a scandal and a tragedy. What do you think are the most powerful tools to try and affect change? Is it from parents? Should it be from government? Should it be from national associations?
Well, it's the job of the national associations, but they don't do anything because the majority of pediatric surgeons resist. So on a democratic way, you won't reach it in the associations. The government will only move if there are strong initiatives bringing them to deal with this rare condition. They are busy with other problems, especially at the moment. So it's up to the patient organizations, the parent initiatives, and they brought about change in the UK with the biliary atresia, and it looks like they are the ones who founded the European reference networks of rare diseases. This is an initiative of EUROGEN. 1,000 patient organizations for rare organizations went to the EU and they brought about change. So the table we are sitting on is built by the patient organizations. And I think they are the ones who will bring about change, which is a shame because it would be our professional responsibility to do so, but we are unable. So we should support the patient organizations in their efforts.
However, Eberhard, I must add something that a joint effort between patients' organization and surgeons will help a lot. I do believe that it's going to help if the patients' organization will work with the pediatric surgeons, for example, in this case, and bring this issue to the government together with the national alliances, of course.
Mm-hmm.
Okay. Yeah. Okay. Thank you, Joe, for that question. One other comment or question we've got, another one from Taurai again. I hope I'm pronouncing that name correct, so apologies if not. Do you envision super specialization as another solution or approach, e.g. having an arm paediatric colorectal surgeon, for example?
Sorry, I didn't get that question. Can you please repeat it slowly?
Yeah, sorry.
For a foreigner?
Do you see another solution as being super specialization? For example, having an ARM, an ARM, paediatric colorectal surgeon. So I think it's a very specialist, incredibly specialist surgeon.
Whether we see another solution, but only this super specialization.
Well, is the super specialization as another solution, as a possible solution?
Yeah, I think it's the only solution, because if you have a center with really high case numbers, they are busy, extremely busy. At the moment, we don't have the hospitals, we don't have the nurses to staff it. But if you have such a center, if you envision such a center, not every surgeon in this center will do every surgery there. You will have specialists for this and that. Yes, super specialization is inevitable. We already have it in adult surgery, you know, in visceral surgery. It's quite common. It's everyday life. So in pediatric surgery, it's a little bit more difficult. We are some decades behind and our patient numbers are even smaller, but we have to move into the same direction.
Okay, thank you. That's all the questions I think that we have, and we don't have anybody else raising their hands. So I'll just give everybody one last opportunity if they want to, if someone wants to come in. Yeah, let's just comment from Graham Slater, who says, as the lead patient rep for Ernica, I would like to thank Eberhard and Dalia for their presentation and exposing this significant issue. So thank you, Graham, for that comment.
Thank you.
Okay, well, I think if there's nothing else, I'd just like to thank another one coming in just as I say that. There's a comment from Kate saying many adults are told they are fixed at surgery.
I just want to say, thank everybody for being here. We had 80% pediatric surgeons, which is very interesting. And those numbers about transition, treating adults, etc., we will look at the recording and discuss it afterwards together. Dalia, I think.
Yes, I think so.
So this was really a treasure to have this time together with you. Thank you very much. Dalia, final word to you.
Thank you very much, everybody, because it was important also for me to bring up the point of view of the patients. Thank you.
And also
thank you, Darren, for smoothly running it.
Thank you. It went very well. That's good. Thank you. So, but thank you, Dalia. Thank you, Eberhard, for taking the time to do this as well. Much appreciated. And so thank you to everyone who attended as well. As I said, the recordings will be available tomorrow. We'll send the direct link out to those recordings once they're done. My colleague Luce will be doing that. So in the meantime, please do check out our YouTube channel. We recently reached over 500 subscribers on that. Wow. So please go and if you haven't subscribed already, please do so. That would be very helpful for us. And also look out, we put on the rest. I've also added the remaining webinars for this year to our website, so you can see all the webinars remaining. There was a message on there as well. We are currently planning our 2023 webinar schedule. We've got a few in at the moment. We're just arranging a few more. Once we've done that, we will put some of those onto the website as well. So thank you very much, everybody. Thank you again to the presenters, much appreciated. And I hope everyone has a good evening, and take care, everybody. Thank you.
Thank you very much.
Bye-bye.
Bye-bye.